Yeah, politics, post-truth science and COVID-19. So well, the first thing to do is to thank the funders of my research. Hopefully you'll see the slides in just a second. It always takes a little bit of time to load up. But we got some funding from the COVID-19 Emergency Fund and also Wellcome Trust, where I've got a Senior Investigator Award, and NIHR. We've also got Health Foundation, actually, since I made this slide now. Yeah, I guess this is a social policy talk. So it's I think the kind of interface between medicine and policy has been one of the major things in 2020, you know, right around the world, of course. And it's not, I think, unrelated that we've also had, you know, if you remember this time last year, everyone was sort of arguing about Brexit, and it was all about we've had enough of experts and all that kind of thing. Well, I think all those issues are going to be tied up in what I've got to talk about today. But let's just go straight in and give you some examples. And I could have picked a lot of different examples, but I've given you one on the left here. Standard science, I've called it, easy translation. We all know the example of dexamethasone for severely ill patients with COVID-19. Randomized controlled trials of dexamethasone versus placebo were, relatively speaking, easy to do. The patients were lying in their beds, the drug was already available, all that kind of thing. And these trials quickly produced definitive evidence. We now know that this stuff works for certain cohorts of patients. We know how well it works, how much it reduces mortality by, all that kind of thing. And there's not a lot of doubt about that. The other thing is that the findings were pretty generalizable, and the findings from those trials were quickly kind of implemented around the world in different settings, because guess what? If you're sick with COVID on the ITU in one country, you're not that different from someone who's got the same disease in another country. Now, there's an area of work that I've been involved in, as many of you know, and I've called it contested science and tricky translation. Masks, face coverings, whatever you call them, for preventing the spread of COVID-19. There were no randomized controlled trials. Maybe those trials were impossible. I was actually on a webinar earlier on today talking about the Denmark 19 trial, the Danish study that's recently been published. You can say, well, you can't say they were impossible because the Denmark people did a randomized controlled trial, but it wasn't a trial of preventing the spread of COVID-19. It was a trial of masks to protect the wearer. Those of you who heard that earlier webinar know that there were quite a few problems with that trial, but nevertheless, at the time, you know, earlier on in the pandemic, there really were no randomized controlled trials, not even flawed ones. And masking very quickly, as we all know, became a political issue, and scientists either chose to take sides or were depicted as having taken sides. Now let's go back to what I've presented to you as a very straightforward example of scientific evidence. We all know the term evidence-based medicine, which for the purposes of this talk, I'm going to define as nice, clean experiments on well-defined population samples, which produce definitive findings that can be handed to policymakers. And that's, of course, exactly what happened here. And we have the politicians and policymakers standing up and talking about the results of the DEX trial. This triangle you may have seen, you may have been taught it, you may have had to memorize it and reproduce it in an exam. It's a very important rhetorical device. It is depicting certain types of study design as better than certain other types. Level 1 evidence, that's the best kind of evidence according to this argument. Randomized controlled trials and systematic reviews of such trials. And then you go down through the rainbow with study designs depicted as lesser quality, inherently lower quality, because of the methodology. So this is a hierarchy of methodological design. So inherent in this hierarchy of evidence is the assumption that method will define what is high quality science. And I'm going to come back to that, as you can imagine. Now, this is a slightly old screenshot. It's actually from a screen that is still up, but it's from the Center for Evidence-Based Medicine website. And I'm not really here to criticize or personalize this against the people who put together this website. They're from my own department, and indeed I worked very closely with these people at the beginning of the pandemic on the COVID-19 evidence program. But one area where we came to disagree was on what the evidence on masks, not what the evidence was, but how to interpret it. We all agreed what the evidence was. Now, Hennigan and Jefferson did, the first thing they did, you can see what I've done here with these pictures, they took the red triangle from the hierarchy of evidence, and metaphorically at least, they threw the rest of the studies in the bin. Anything that wasn't a randomized controlled trial, they rejected as being of lower quality evidence. And what they then did was a very technically correct review of the trials that were left. And they concluded evidence from 14 trials on the use of masks versus no masks was disappointing. It showed no effect in either healthcare workers or in community settings. And so this was certainly presented as a very neat analysis, because the first thing they did was they threw away the poor evidence and then they summarized the better evidence using mathematical techniques. And then actually they handed this to a number of policymakers, not just in the UK, but worldwide. Now, I just want to sort of analyze what was happening here. And I'm going to draw on a paper by my colleague Eivind Engebretsen from the University of Oslo. You may not know this paper, but I would really encourage you to get hold of it and have a look at it. Because what they're doing is they're using a critical social science and critical linguistics approach to look at what we mean by knowledge translation. The parrot is something I've put there because the implication in a lot of knowledge translation work from the medical field is that translating knowledge into policy is like being a bilingual parrot. In other words, you take the facts which you've objectively obtained by your good scientific method, and then you hand them to the policymaker with the facts kind of pass through you, but you don't change them. So the idea is that there is no judgment involved. It's a technical process to throw away the studies that were not randomized, for example, and then to apply the risk of bias tool, for example, to find out which ones were unbiased, and then to add those up. Now, what Engebretsen and his colleagues are arguing is actually translation from one language to another is never done by a bilingual parrot. Rather, it involves judgments, it involves compromises, it involves attention to different audiences and contexts. And any of you who've worked as a translator or tried to translate something from one language to another. I used to have a job actually translating a medical journal from French into English. And actually you couldn't translate things directly because it just wouldn't translate. Now, similarly, these people argue translation of research evidence is never a simple act of summarizing and handing over the facts, but rather it involves judgments and choices which are actually driven by values. And they draw on the critical linguist, Jacques Derrida, to say this, and I think this is a really important quote. The translational act itself is considered by the scientist to be a non-act, and the translator a non-actor. The purpose of translation is assumed to be a container of the original message without adding, transforming, or otherwise betraying the original. And one of the things I've become quite fascinated by is the sense that the scientists can do this without themselves being involved. Now, right back in April, this statement was put out on the website of the Centre for Evidence-Based Medicine. Thinking you're protected means you may put yourself at higher risk. Measures we can take implicitly instead of masking. Now that in the square brackets, that's what I've added, but I think this is what they're saying. Measures we can take can include washing hands, avoiding touching, social distancing, school closures, and self-isolating when unwell. And then they say, you may also end up touching your face more often. And again, I've added for clarification, I think they mean if you're wearing a mask. And then they say a mask can become dirty with excessive moisture and contaminated with airborne pathogens. So they put all that in. And I think the day after this went up, or certainly within a week of it going up, we had the policymakers from Public Health England saying something very interesting. We are following the science. So the definite article was used, the science. And they said, while the practice of wearing masks seems wired into some Southeast Asian cultures, there's no evidence that general wearing of face masks by the public who are well affects the spread of the disease in our society. So there was quite an interesting, I mean, some people would call this othering, that those Asian cultures, they're a bit strange. They just do it. They just wear masks because that's what they do. But in our society, we've got the evidence that there was really no evidence to introduce them here. Now, sometime later, actually in September 2020, Scott Atlas, who at the time was advising President Trump, was actually quoting Professor Hennigan and the Oxford Centre for Evidence-Based Medicine on the lack of efficacy of masks. So this was directly picked up by an advisor who was not going down too well with mainstream scientists in the United States. Sometime after the statements about masks had been made, a couple of papers came out which didn't really get noticed too much, but there was a narrative review published in the British Medical Journal, which showed this idea of risk compensation actually doesn't happen with masks. And in fact, these people, the team was led by Dame Teresa Marto from Cambridge, and they found actually what happens is that when you're wearing a mask, you're more likely to socially distance, you're more likely to wash your hands, all that kind of thing. So that was quite an interesting paper. And then there was another paper came out in JAMA in, I think that was in July as well, showing that people touch their face less if they're wearing a mask. You might notice it more, but actually if you objectively count the number of times people touch their face, and they did this by videoing people going into past a camera in a railway station, I think, but they had thousands and thousands of examples of whether people were or weren't wearing the mask. So all this, very interesting. Now let's just have a look at what was ignored, what was thrown in the bin. Do you remember I showed you that picture of the rest of the hierarchy of evidence being thrown in the bin? Well, sneeze videos got thrown in the bin. So I've been working with a woman who's a professor of sneeze medicine, or she's actually a fluid dynamics professor, and does these amazing pictures where you light up the droplets coming out of someone's mouth and nose, but you also use clever physics to measure the turbulent gas clouds that come out when we cough or shout and things like that. But actually those were deemed on a methodological level right down in the blue bit of the hierarchy of evidence. So they were ignored. And equally in the blue bit, as poor quality evidence, as defined by evidence-based medicine, were choir stories. I mean, look at this choir singing away. And here's a paper published in the CDC's Morbidity and Mortality Weekly Report, so normally seen as very high quality journal. In fact, it's a story about a choir singing. And most of that choir, I think it was 52 out of 60, caught COVID, 2 of them died. And it was one of the first super spreader events. But these kind of accounts were not seen as scientific. They were defined as non-science. And I don't want to go through the detail of this, but I do think we need to stand back and say, no, hang on a minute, on what grounds did evidence-based medicine say, no, all this can go in the bin? Another kind of evidence that they didn't want to look at and still don't want to look at are the natural experiments of countries that either did or did not introduce masking within a month of the first case. So the orange and the blue lines are mortality over time in countries that introduce masks very quickly, and the red are the ones that introduce masks much later or not at all. And you can see orders of magnitude difference in the deaths. Now you can say, well, hang on a minute, what about New Zealand? They didn't introduce masks, but they had a very low death rate. New Zealand is in that red line. It's just an outlier in that sample. So I'm sure that we could talk a lot about those natural experiments, but the point was evidence-based medicine didn't want to talk about them. They didn't want to argue. They didn't want to engage because these were not randomized controlled trials. And so an awful lot of evidence, mechanistic evidence, we sometimes call it, was ignored and put aside. So what we had here was two arguments, two discourses, if you like. The first is illustrated by this tweet from KK Cheng, who's a professor of public health and primary care, I think, in Birmingham. And he's saying the cloth mask is a cheap measure. It's got a lot of mechanistic evidence for blocking droplets. And he's claiming there is definitive proof of lack of harm because in Hong Kong, where everybody wears masks, there's only been 4 deaths. And if masks actually caused harm, surely there would have been more deaths. And then Paul Glasziou, who used to work in our department, is now in Australia, very keen evidence-based medicine professor. And he then puts the alternative argument, masks are unlikely to protect you, unclear if it protects others. So he's basing his claims purely on the randomized controlled trials. He's not engaging at all with the mechanistic evidence. Well, right back in March, we wrote a paper. It was published on the 2nd of April, and we said, look, the evidence is not conclusive either way, but it's pointing in the direction that there could be a really important effect here. And if there is, an awful lot of lives could be saved. So we were very kind of circumspect here, but we said, let's use the precautionary principle because the likelihood that they cause large amounts of harm is small. Why don't we do it? That it didn't change policy for another couple of months, but it certainly caused controversy. And what happened, and this is what I want to move to now, is I want to look at how this paper was received right back in April. And that was at a time when not many people were very keen on masks. It's all changed a bit now. So here's 2 different websites, both of which were set up to attack not just my work, but also my character. And I think they're talking about the same paper, but they're making diametrically opposite criticisms. So the first criticism, and actually this is from a professor of public health, the criticism is that I'm absolutely sure that I'm right. And you can see from the language used that this is a criticism of me. I've led the successful charge to make face masks mandatory. So I've been charging away. And I'm sure I'm right, and I've been decimating other people's arguments. So I'm sort of crashing around here with my personal views and my confidence. The second website, which is still up actually, you can go to this chap's website. He's got several of these about me. He has found one of my papers, which he says is a nonsense paper. And what he doesn't like about it is that I'm too circumspect. The paper is larded with may this, and it seems likely that, and it's all very turgid. It's a smokescreen because I'm just not sure what I want. So this is the kind of thing that has now been that's been published, and some people drink it in. I don't think that many people do, but it's quite interesting. Anyway, the next slide I've got to show you is, well, I'll show it now actually, is a message which was posted in the chat room when I gave a Zoom lecture on masks from Green Templeton College. So somebody had joined the, just like some of you have done today. I know there's sort of 150 people on this call, and there may be a few people posting that kind of stuff in the chat today. I don't know, I haven't looked. But this happened before I'd even started. I was only on my opening slide, and this kind of thing came. Now, this is extraordinary that we are giving lectures in Oxford colleges and we're opening them to the public. You know, this often happened before. People could wander in and sit down. But now what we've got is really very aggressive, very abusive expletives. The asterisks were not there, by the way. I've taken them out for your comfort. The person had signed in with a white male name, might not have been a white male, but certainly wanted us to think that they were a white male. Now, against all this, and I'm sure we'll have lots of discussion afterwards, I'm looking forward to that. We have here 3 professors, all of whom I think are very sincere. They feel very strongly about a set of issues, and they set up something called the Great Barrington Declaration, which I'm sure many of you have heard of. And their basic argument, as I interpret it, is that COVID isn't as bad as it's claimed, especially in the healthy under 60s, that the evidence base for interfering with people's lives is weak, and that the economy should be prioritized over further lockdown. And a few of us got together and produced a different declaration called the Jon Snow Memorandum. We felt that COVID is a very serious and sometimes deadly disease, that all citizens count. We can't just sort of brush people aside because they're over 60 or sick in some way, preconditions, all that kind of thing. We argued that the best way to save the economy is to address public health, and that we all need to make compromises for the good of society. So the reason why we put out the Jon Snow Memorandum was because the Great Barrington Declaration had been launched with really a lot of press interest. It was all over the front pages of all the newspapers, not just in this country, but around the world. And we felt it would be a good idea for scientists to get together to make another declaration. You know, this is not something I enjoy doing, but equally, we didn't feel that the only scientific statement of purpose should be that one. The British Medical Journal covered this in terms of 2 camps. Actually, this was relating to something that happened just prior to the Great Barrington. This was another set of letters which were really the precursors for those, but you can see the way we have now become the story, if you like. Scientists are disagreeing with each other. The press were also quite interested in who was funding particular work, and also who was paying for the people to be flown around the world. I should add that Carl Hennigan did not sign the Great Barrington Declaration. He was involved in the earlier letter. In fact, I think he was one of the lead signatories, but he stepped back from signing the Great Barrington Declaration. I haven't asked him why. But certainly the media, the investigative journalists were onto this and describing this work as fringe pseudoscience. This is not mainstream. This is something that is a kind of outlier in the range of scientific opinion, but it's also been co-drafted by people with, if you like, their political interests and economic interests, and not just scientific ones. There have been a number of papers written about the populist right, strongly libertarian, anti-masks, anti-lockdown, pro-segmentation, the argument that the old and vulnerable should stay at home, and also this whole notion of herd immunity, that let the disease just sweep across the population, but let's not interfere with people's freedom. And a very interesting paper, actually written by a man, Jason Harsin, but it's all about what he calls toxic white masculinity, post-truth politics, and the COVID-19 infodemic. And what he says here is that the proponents of this libertarian argument tend to be, although they are not necessarily white and male, they tend to be aggressively confident, very hierarchical, and dismissive of traditionally female traits such as emotionality, such as the desire to share power, and also admission of uncertainty. It's a great paper, this, actually, because he describes various pastors of churches in America who stand up and tell their congregations, look, don't wear masks because it's a sign of weakness and a sign of ungodliness. So they're sort of tying up these particular interpretations of the evidence base with overt politicization and linking with the libertarian agenda. Now, I want to talk a little bit about post-truth, which the Oxford English Dictionary defines as relating to or denoting circumstances in which objective facts are less influential in shaping public opinion than appeals to emotion and personal belief. And there's been a conference in June, COVID-19 in the post-truth age, and Roy Schulman, in summarizing that, has described the COVID pandemic as a unique phenomenon constituting the most blatant expression of dangers in the post-truth age. The period of the pandemic has been characterized by less confidence in institutions, a lack of agreement on facts, and a blurring of the line between opinion and fact. And he goes on to say the pandemic intensified the need of citizens to find certainty, but they've tended to find it in comfortable facts, in inverted commas, from institutions and entities that they regard as trustworthy and that are consistent with opinions they already espouse. So I find this quite a sort of quite resonant with my own experience of what's been happening, certainly to me as a scientist. Now, I don't want to draw too many parallels because I think this possibly overdoes it a bit, but I think there may be some links to what Hannah Arendt was writing about when she wrote her book Men in Dark Times. Of course, post-truth hadn't been invented as a term there, but what she says here is, if it is the function of the public realm to throw light on the affairs of men, then darkness has come when this light is extinguished by credibility gaps and invisible government, by speech that does not disclose what is, but sweeps it under the carpet, by exhortations, moral and otherwise, that under the pretext of upholding old truths, degrade all truths to meaningless triviality. So that's getting really quite scary, I think. So let me summarize. Post-truth science. In 2020, we had COVID-19, research progressed at unprecedented pace and scale. Too little scientific knowledge quickly became too much. We were flooded with preprints, remember all that. Facts, in many cases, were contested and became saturated with ideology. Uncertainty became a weapon to be used tactically by interest groups. And scientists, we scientists, our flawed assumptions, our political allegiances, our interpersonal rivalries, our private lives became the story. So as I prepare to write a book chapter on this, I've been actually asked to write a book chapter for the Handbook of Qualitative Research by Denzin and Lincoln. So I've been getting together thinking, well, what do I say about this? How can scientists survive? Because this may be the future of science. Is it going to get any better? Well, I've worked out 4 approaches to surviving in this highly toxic environment, high pressure environment. And the first is reflexivity. Those of you who are from Oxford will recognize that picture. It's of the River Thames near Port Meadow. This is in the summer. I've actually been off there today, and it doesn't look quite like that today. I go there every day. I spend an hour. I actually swim up and down, but you don't have to do that. You can sit on the edge. But it's really, really important to get away from your work and to reflect and to have some headspace. And I don't think even when I was under huge pressure at the beginning, I don't think there was a day when I missed that hour of reflexivity in the morning. Secondly, and not so pleasant, painful engagement. I have to read what they write about my work. I have to engage, not necessarily read every word, but in order to counter the arguments, I've got to get my head around them. Thirdly, and I would love to have a discussion with you afterwards about this, what I've called epistemological labor. I have written a lot of articles this year, some in previous years, but I've written an awful lot of articles about why that hierarchy of evidence is not the last word in the philosophy of science. What are its assumptions? Not just let's throw away all the rainbow except the red, but where did this rainbow come from? Whose interests does it serve? What does it leave out? Those kind of things. So working on the epistemological arguments as well as the empirical ones. And finally, deconstruction. It was pretty tough going through the Great Barrington Declaration. It was a mishmash of some things that were absolutely correct, some things that were extreme interpretations of particular scientific data, and a lot of ideology. And unpacking that kind of intertwining of science and ideology, deconstructing it, and presenting counter arguments to the actual claims that were made. So, for example, if we want to deconstruct the science of masks, we need to ask what counts as facts and how those facts become legitimate. It's perfectly okay to look at a mask as PPE, in other words, personal protective equipment, something that needs to be tested like a drug in a randomized controlled trial. You can only do that for protecting the wearer, of course, because the person you're randomizing is also the person that you're going to have to do the tests on. That's fine, but what does that leave out? You could also look at masks through a more political lens, linked to very controversial choices, hidden vested interests, who's getting the contracts for the supply of PPE, why is the supply chain breaking down, all that kind of thing. So it's the fact that you can do RCTs of masks in protecting the wearer doesn't mean that that's all you need to question about the subject of masks. Martin McKee and Michelle Kelly-Irving and I wrote a piece for The Guardian a few weeks ago. We were asked to write about herd immunity. We were asked to scientifically deconstruct the Great Barrington Declaration. We decided we weren't going to do that. We decided, no, we're going to say that's not the question that needs to be asked. The question that needs to be asked is who is funding, we said, the bad science. We said that there's very little evidence, or there's no evidence that their main claims are supported by science, and therefore we're not going to engage with that. What we're going to engage with is where they're getting their money from, and that's what we wrote about. I've just given you here some examples from my own work, along with some of the people in my team, about the epistemological labor type articles that I've written. I think there's some others, and I think maybe some of you on the call have also co-authored papers with me, so hopefully we'll have a bit of a discussion there. So that's the end of my presentation, but I now hope we've got a bit of time to discuss and talk. So I will now stop sharing my screen. There we go.